Hello. My intention is to complete peripheral nerve problems in the next hour to hour and a half, and then post these videos on YouTube with links off the blackboard. They should be in 10-minute intervals. I am actually going to be downtown at a 2-day conference on cardiology subjects. Looking forward to that. There's some pretty interesting stuff in this peripheral nerve problem section. I hope you find it so. Hope your test went well this morning. Yeah, I will not have looked at it yet, but I'll get to it as soon as I can. We're going to start with cranial nerve problems. We'll talk specifically about trigeminal neuralgia and Bell's palsy, and then we'll move to the polyneuropathies. Now, the cranial nerve problems usually involve a single nerve. Remember that there's 12 pairs of cranial nerves that are considered the periphery nerves of the brain. And then the polyneuropathies occur when there are many peripheral nerves throughout the body that malfunction. Specifically, we're going to look at Guillain-Barré, botulism, and tetanus. First of all, we will talk about trigeminal neuralgia. This is a disorder of the fifth cranial nerve. It causes intense, severe electric shock-like pains, stabbing pains in the areas of the face where the ophthalmic, the maxillary, and the mandibular branches distribute impulses. By many, it's called a suicide disease because it is extremely painful. If you look at a picture of the head, here's your brainstem, and the trigeminal nerve, fifth cranial nerve, comes off the brainstem. You've got the nerve nucleus. You've got the trigeminal nerve root. There's a ganglion here, and that ganglion will show up again when we look at some treatment options. There are 3 nerve divisions: the ophthalmic, the mandibular, the maxillary. You can see their distribution. The fifth cranial nerve has both motor and sensory branches. In the trigeminal neuralgia, it's the sensory branches, especially the maxillary and the mandibular, that are involved. If you look here, you can see this is the areas of the face that are covered by the maxillary branch. Maxillary branch. And then this area down here is what addresses the mandibular portion. The ophthalmic is on up higher. It's relatively uncommon, but it is still the most commonly diagnosed neuralgic condition. The annual incidence is 4 to 5 per 100,000, and that's about 15,000 Americans per year. Most of these people are over 40, and I've mentioned already that it's the maxillary and mandibular branches of the trigeminal nerve that are affected most of the time. It's the afferent branches. The afferent is your sensory branch. There's some kind of a neurologic structure or function change due to irritation or damage of that nerve. Some known or suspected causes include things like blood vessel pressing on the root of the trigeminal nerve, multiple sclerosis due to demyelinization in advanced stages can cause TN. High blood pressure is also a risk factor. Physical damage to the nerve from an injury or a dental surgical procedure or an infection. 15% of the time, patients will have an underlying structural cause that can be identified, like a tumor. There is a genetic association, although exactly why is not known. 4% in unilateral, 17% in bilateral trigeminal neuralgia will have a close relative with trigeminal neuralgia, and that would be compared to 1 in 15,000 when there is no close relative. So that does seem to indicate that inheritance or genetics is probably a factor. So again, chronic irritation of the trigeminal nerve at that root entry from compression of the superior subcerebellar artery. In some subsequent pictures, I'll show you how the cerebellar artery crosses over the trigeminal nerve. Some other factors could include herpes infection, infection of the jaw and teeth. Sometimes a brainstem infarction can cause irritation of the trigeminal nerve. This irritation then increases firing of the sensory fibers. Your clinical manifestations are identified here. Things like burning, knife-like shock. You see the distribution there. It's intense pain. There can be a tic or grimacing or twitching or tearing of the eye that's associated. Sometimes there's some sensory loss. The attacks last seconds to minutes. They're unpredictable, unilateral. They can happen several times a day, or they can be weeks or months apart. Clustering refers to a cycle of pain and refractoriness that continues for hours. Then after the refractory or the pain-free period, then the pain happens again. The attack can last seconds to 2 to 3 minutes, and exactly when it's going to happen is just not predictable. The painful episodes are usually initiated by a triggering mechanism of light cutaneous, which refers to skin stimulation, at some specific points along the distribution of the nerve branches. Touch and tickle are the predominant triggers. The precipitating stimuli might include things like chewing, brushing your teeth, a hot or a cold blast on the face, washing your face, yawning, even talking. Trigeminal neuralgia is a non-nociceptive pain, and that's different from a nociceptive pain. The difference between the two, non-nociceptive pain is a neuropathic pain. That pain comes from within the nervous system itself. It is not related to activation of pain receptors. So the nerve itself is sending pain messages either because it's faulty or because it's irritated, rather than nociceptive pain, and that's spelled, by the way, nociceptive is N-O-C-I-C-E-P-T-I-V-E. That's nociceptive. And that means that the pain receptors sense a temperature or a vibration or a stretch, or there's some chemical from damaged cells that cause the nerve to transfer this pain. Non-nociceptive pain, as I mentioned, comes from within the nerve itself. So as a result of this pain, the patient may eat improperly, they may not have proper hygiene, they may wear a cloth over their face, they may withdraw, they may sleep excessively. Trigeminal neuralgia is very disruptive to the lifestyle and can be extremely depressive in its in the way that it affects people. Well, that is probably a 10-minute segment, so I'm going to stop it and I will be back.